Hi, I'm Autumn Sanderson, and this is video 1 to my hemodynamics and circulatory shock presentation for respiratory 2480. We're going to start off with an introduction. So what is hemodynamics? Hemodynamics is how our blood flows through our vessels and how it affects our circulation. And so many factors can affect how well the blood can move throughout our body. Our heart and our blood vessels can make adjustments to deliver enough oxygen to our body to meet our body's oxygenation needs. There's many conditions that affect our circulatory system that can make it less efficient in delivering blood to our organs. So why is this important? If our organs are not getting the blood that they need, then the risk is that they will start to die off, and that can be fatal. So what is shock? Shock is a medical emergency when our organs and our tissues don't get the adequate blood flow or oxygen that they need. Then this can occur. And in addition, this also allows the buildup of waste products, meaning that it could also result in serious damage or even death. There's 4 types of shocks that we're going to go over in this presentation, and those include hypovolemic shock, which occurs due to a loss of blood or fluid, distributive shock, and this can be caused by heart failure, cardiogenic shock, which is abnormal blood vessel dilation, and obstructive shock, and this can be caused by a physical blockage of blood flow. Okay, we're now moving on to our second video of our hemodynamics and circulatory shock presentation. And in this video, we're going to be talking about hypovolemic shock. So what is hypovolemic shock? This is a dangerous condition where the body has lost a large amount of fluid or blood. This could be due to sweating, vomiting, diarrhea, blood loss, etc. And this loss of blood volume or fluid volume can result in a drop in blood pressure. So since our blood is unable to properly circulate and perfuse, there can be many complications that could lead to organ failure. Some of our physical exam findings may or may not include the following. We have an increased work of breathing, so you're going to be breathing faster than normal. Feeling confused or anxious. There could be a lot of sweating, possibly passing out. The skin could be pale and even cool to the touch. Patients might experience weakness, a low temperature and a low blood pressure, an increased pulse rate or heart rate, and little to no urine output. There's 4 stages of hypovolemic shock. We have stage 1, and here you've only lost about 15% of your body's blood, and your pressure and your heart rate might still be normal at this time. In stage 2, here we've lost about 15 to 30% of your body's blood, and at this point your heart rate's going to slowly creep up, and you might even start to breathe a little bit faster. In stage 3, you've lost about 30 to 40% of your blood, and here's when your blood pressure starts to tank. It's going to drop very low, and your heart rate and your breathing is going to increase. And you're also going to see issues with your urine output. It's going to be much more difficult to urinate. And then in stage 4, here you've lost more than 40% of your body's blood or fluids, and your blood pressure is significantly low, your heart rate is critically high, and you are producing very little or no urine output. How it's diagnosed and monitored. There are several ways that we can diagnose and monitor hypovolemic shock, but the most typical are going to be your blood tests, an EKG, an echocardiogram, a right heart catheter, also known as a Swan-Ganz, CT or other imaging, such as an X-ray, and an endoscopy if needed. Some significance of our imaging is that imaging, especially with CTs or even X-rays, depending on what organ we're looking at, they might show an increase in vasculature. So this could mean seeing increased vasculature, but also a diminished inferior vena cava diameter if we're looking at, say, a chest X-ray. So right here, this is going to be an example of a chest CT. where you can very clearly see that the vasculature is a lot more noticeable, it's thicker, and it's more apparent. And then here is a chest x-ray. You can see a lot of vasculature, especially there in the middle surrounding our cardiac silhouette. Okay, our hemodynamic values. Our low values are going to be our CVP, our PCWP, our cardiac output. Again, urine output, low. And then high is going to be that systemic vascular resistance. It's going to be important to monitor these because it's going to help see what fluids need replenished and how we can proceed with treatment. So treating hypovolemic shock, you're going to get fluids or blood products depending on what your body is low on. Vasopressors, epinephrine, norepi, inotropic agents to help with the contractibility of the heart. So an example of this would be dopamine. And then you might also get adjunct treatment such as TXA if you might be experiencing uncontrolled bleeding. Our ABG results are going to be mostly metabolic acidosis. This is going to be the most common finding. So you're going to have a low pH, a low CO2, a low bicarb, and a low PaO2. Your lactate is going to be pretty high, and this is common with hypoxic tissue and more severe shocks. As far as mechanical ventilation goes, we want low tidal volumes with a high frequency and rate. Think protective lung. And it's okay to have a little bit of CO2 retention because, again, we're trying to not cause any lung injuries. And you also want to avoid high peeps because the higher the peep, the more we might worsen our hemodynamic values. So in summary, we've gone over what hypovolemic shock is, its physical signs and symptoms, how it's diagnosed, including imaging, its hemodynamic values, how it's treated, its ABG results, and its mechanical ventilator settings. This is video 3 of our hemodynamics and circulatory shock presentation. And in this one, we are going to talk about distributive shock. So what is distributive shock? It's also known as vasodilatory shock, and it is a medical emergency where your body can't get enough blood to your heart, brain, or kidneys. This can happen because your blood vessels are dilated, you're going to have a low blood pressure, and your body is going to be limited to how much blood can get to your tissues and your organs. So often your capillaries are leaky in this type of shock, and that can result in some fluid loss. Examples of distributive shock could be septic shock. That's one of the most common. Anaphylactic shock due to a severe allergic reaction, and even asthma attacks. Some common physical exam findings could include skin rash, skin that is initially warm, but it can turn cold and clammy, warm arms and legs, fevers and chills, an increased heart rate and work of breathing, a low blood pressure, abdominal pain, confusion, cough and or shortness of breath, nausea and or vomiting, or pain when urinating. With distributive shock, there are several ways that we can diagnose it, and there's different imaging as well. Of course, we're going to have our physical exam. We're going to look for all of those signs and symptoms that we just listed. And we're also going to go over a history. The history here is really important, especially if somebody is experiencing anaphylactic shock. The patient themselves might not be able to give you their medical history, but if they have someone with them, let's say a friend or a family member, who might be able to offer a little bit more of a medical history, that is super helpful in figuring out what may have caused a severe reaction. But we're also going to want to look at some blood tests. We're going to do an EKG. Our initial imaging, however, will be a chest x-ray. And then a chest CT might be needed as well. This is going to be what we will want to get, especially if a patient is suspected of having sepsis that is in conjunction with the abdomen. We'll also want to do an ultrasound if our heart, lungs, or abdomen are affected. This can detect fluid, and then an echocardiogram. So here we have a patient who has severe pneumonia that has gone septic and has now gone into distributive shock. So you can see a lot of nastiness going on in both of the lungs, especially here in the bases. Our bases are super consolidated. With our hemodynamic monitoring, non-invasive ways that we can do this, of course, is our echocardiogram. We're going to be monitoring our blood pressure with a cuff and continuous pulse ox. Our invasive hemodynamic monitoring, however, is going to include a central venous catheter, a Swan Ganz, and an arterial line. Our low values are going to be our CVP, our MAP, our SVR, which is going to be most common. And we could have a low pulmonary capillary wedge pressure, but sometimes this is normal in distributive shock. And then our high values are going to be our cardiac index and our SpO2. Treatment for distributive shock is going to include fluids, mostly given through IV. And then you're going to have medications that are focused on treating whatever the shock cause is. So, for example, if we have an infection, you're going to get antibiotics. If you're having an allergic reaction, you're going to get an antihistamine. Steroids are commonly given for allergic reactions or sepsis. These could be systemic or they could be corticosteroids. Vasopressors are going to help with our blood pressure. An example of this is epinephrine. You might get albuterol if the shock is due to an asthma attack to help dilate those airways. And then possible tube feedings for nutrition if needed. ABG results. So early on, you're going to see ABGs that are showing respiratory alkalosis. So you're going to have a high pH, a low CO2, a normal bicarb, and a high lactate. So like we said in previous videos, a high lactate especially is pretty common for patients who are suffering from shock. Late ABG results for distributive shock are going to show metabolic acidosis. So a low pH, a low CO2, a low bicarb, and an even higher lactate. For mechanical ventilation, volume control is the preferred mode. We want a normal tidal volume, so think 6 to 8 milliliters per kilogram of ideal body weight. We're going to have a normal frequency or rate somewhere between, say, 12 and 18. And then we are going to have a PEEP of 5 to 10 centimeters of water pressure. Again, we want to avoid the high PEEP because we don't want to affect our blood pressure or hemodynamics any more than they already are. So to summarize distributive shock, we have gone over what distributive shock is, its signs and symptoms, how it's diagnosed, along with its imaging. We've talked about its hemodynamics, how it's monitored, and what those values are. We've discussed how it's treated and what early and late ABGs look like. And we talked about how its mechanical event settings are initially set. This is part 4 of our hemodynamics and circulatory shock presentation. And in this video, we are going to discuss cardiogenic shock. So what is cardiogenic shock? This is a life-threatening condition where the heart cannot supply enough oxygenated blood to the body. Without this oxygen, organs cannot function and they may even go into organ failure, and in severe cases, death can result. Common causes of cardiogenic shock can include an MI or a heart attack, a pulmonary embolism, endocarditis, myocarditis, and etc. So cardiogenic shock, because it has a lot of different causes, you might come across several of these common physical exam findings. I'm going to go ahead and list out what some of those may or may not be, including chest pain. Some people also claim to have a heartburn type feeling. upper body or pain radiating in the left arm, upper abdominal, throat, or even jaw pain, trouble or increased work of breathing, sweating or a cold sweat. You might feel generalized weakness or anxiety, lightheadedness, an increased or irregular heart rate, a weaker thready pulse, confusion, fainting. You might hear lung crackles throughout the lungs when you listen with a stethoscope, a low blood pressure, a decreased urine output, cold hands or feet, pale skin, fatigue, a decrease in appetite, and even edema, most likely in the abdomen or the legs. So, how is cardiogenic shock diagnosed, and what does its imaging look like? So, of course, we're going to do a physical exam, and we're going to look for all of those signs and symptoms that we just talked about. Cardiac catheterization is another way to diagnose cardiogenic shock. We're also going to do an EKG, of course, and an echocardiogram. The echocardiogram is going to help us identify the cause of shock. A chest x-ray can be useful for excluding other causes of shock. And a chest CT might be helpful, especially for patients with an MI or suspected of an MI. An urgent CT angio will be ordered. An ultrasound and blood tests, including electrolyte levels and cardiac enzymes. So here we have an example of an ultrasound of a patient who is having an MI. For cardiogenic shock, our hemodynamic monitoring is going to be really important. For non-invasive, we're going to have our EKG. We're, of course, going to be looking at our blood pressure. We're going to be using the cuff and a continuous pulse ox to measure our oxygen. Invasive hemodynamic monitoring is going to include a central venous catheter, a Swan-Ganz, and an arterial line. For our values, our low values are going to be our cardiac index and our O2 sats, and our high hemodynamic values are going to be our CVP and our PCWP. Treating cardiogenic shock, we can offer supplemental oxygen, inotropic agents to help with the contractibility of the heart, vasodilators to help open up those blood vessels, antiplatelet agents, these will inhibit platelet aggression, opioids to help with any pain or any stress that might be put on the heart or body, and diuretics to decrease volume or fluid overload. ABG results for cardiogenic shock. Early on, we're going to see patients who are suffering from respiratory alkalosis. They're going to have a high pH, a low CO2, a normal bicarb, and again, a high lactate. And then in cardiogenic shock, our ABG results later are going to show mixed acidosis, severely low pH, a high CO2, a low bicarb, a low PaO2, and a severely high lactate. For mechanical ventilation, we want to focus on improving oxygenation and protecting the airway. And so high flow oxygen is preferred, and we want to try to do non-invasive first before we decide to invasively mechanically ventilate our patients. Sometimes non-invasive ventilation can help, especially when it comes to kind of like pushing that fluid away. And if we can avoid intubating a patient, that is always best. And then some patients might even need ECMO, especially if they have super poor perfusion and blood flow. So in summary, we talked about what cardiogenic shock is, its signs and symptoms, how it's diagnosed and monitored, imaging, its hemodynamics, how it's treated, its early and late ABGs, and its mechanical ventilation and ECMO. This is our final video for hemodynamics and circulatory shock. In this video, we're going to be talking about obstructive shock. So what is obstructive shock? With obstructive shock, something is getting in the way of our blood flow, getting into and out of our heart and great vessels. This can quickly lead to a huge drop in our blood pressure and the amount of blood that is getting to our heart that our heart is able to pump. The shortage of oxygen that this creates is going to affect all of our tissues, all of our organs, and that could lead to organ failure. So this is life-threatening. This needs to be addressed immediately. The heart muscle itself is often fine, but other processes might impair the heart's performance or interfere with it. This could be a clot in our pulmonary artery, fluid around the heart, or high pressures in our chest because of a lung injury, such as a tension pneumothorax. And it's also important to know that this is something that could be caused by a respiratory therapist while a patient is already on a ventilator. Some of the common physical exam findings for obstructive shock might include an increased work of breathing, a low blood pressure, an increased heart rate, confusion, decreased urine output, cool and clammy skin, subcutaneous emphysema, chest or abdominal pain. How do we diagnose obstructive shock and what kind of imaging do we use? So of course, we're going to have our physical exam. Like always, we're going to look for all of those signs and symptoms that we just listed, as well as look at an ultrasound, see if there's any fluid where fluid should not be. We're going to do an echocardiogram to identify our state or our cause of shock. And we're going to perform a CT as early detection of cardiac tamponade. We'll do an EKG and an MRI if needed. So here we have an X-ray image of a patient who has a pretty significant pneumothorax. And this is an example of something that can cause an obstructive shock. So you can see right here that one of the lungs has a lot of air. You don't see any vasculature, while the other side is very whited out. That cardiac silhouette is significantly pushed forward. So our hemodynamics are probably not doing too well. So hemodynamic monitoring for a patient with obstructive shock. We're going to do some non-invasive and invasive. We're going to have our echocardiogram. And of course, we're going to be monitoring our blood pressure continuously with a cuff and our pulse ox continuously. Invasively, we are going to be monitoring with a Swan-Ganz catheter and an arterial line. Our low hemodynamic values will include our cardiac output, our blood pressure, and our pulse pressure. So if you remember the image that I just showed, remember the cardiac silhouette was pushed over to the side due to that pneumothorax. So it's no wonder that all of those values are significantly lower. Our high values are going to be our pulmonary capillary wedge pressure, our CVP, our systemic vascular resistance, and our heart rate. Treatment for obstructive shock is going to include IV fluids and vasopressors. However, we only want to use these temporarily. For our patients who have obstructive shock, we're also going to want to give an inotropic agent if they need it to help with the muscle contracting. But invasive procedures like percutaneous or surgical pericardiocentesis are going to be the standard choice of care. For ABG results, we're going to have a low pH, and early on you're going to have a low CO2, but later on you're going to have a high CO2. That's because in the beginning the patient is probably hyperventilating, so they're blowing off a lot of that CO2, so it's going to show up low on the ABG. But as the patient progresses and their obstructive shock gets worse, the CO2 is going to increase because they are entering respiratory failure. The patient will also have a low bicarb a low PO2, and a high lactate. For mechanical ventilation, a patient can be either put in pressure control or volume control, but we want to be careful with our pressures because we don't want to worsen our hemodynamics or our cardiac tamponade if they have that. We're going to set our tidal volume at a normal value, so 6 to 8 milliliters per kilogram of ideal body weight. We're going to set a normal rate, so 12 to 16, maybe even 12 to 18 for our rate. We want to have a short I time and a long E time. And we want low PEEP again, so that we do not hinder or make worse our hemodynamics or our blood pressure. So in summary, we talked about what cardiogenic shock is, its signs and symptoms, how it's diagnosed and monitored, its imaging, its hemodynamics, how it's monitored and what those values are, how we treat obstructive shock, its ABGs, what it looks like early on, what it looks like later, and its mechanical ventilation modes and settings. And here are my citations.